Good afternoon, Professor Ansell. Thank you so much for accepting our interview today. I'm Dr. Li, and this is Yang, the leader of Hematology Frontier. It's a great honor to have you with us and have meeting for our hematology program.
It's an honor to be here. Thank you.
Thank you so much. It's our great pleasure to talk with you. As a leading expert in Hodgkin lymphoma, your outstanding work on tumor microenvironment, immunoevasion, and immunotherapy has driven tremendous progress across the whole field. So we are very excited to hear your insights today.
Well, thank you. Very nice to be here.
First question. Over the past decade, researchers have gained a deeper understanding of the crosstalk between red stem cells and immune microenvironment. PD-1 blockade had also achieved greater clinical success in Hodgkin lymphoma. From your perspective, what is the most impactful biology discovery in HR research over the last decade? And how has this progress changed our treatment concepts and everyday clinical practice?
That's a good question, and I think generally speaking, the two biggest things that have made an impact for treatment in Hodgkin lymphoma is probably a little bit more than a decade ago, the appreciation that CD30 is highly expressed on the tumor cell, and then over the last decade, an understanding that chromosome 9p21.4 amplification or copy number gain has really been responsible for overexpression of PDL1 and PDL2.
Yeah.
And the ways that's turned into clinical utility is targeting CD30 with brentuximab vedotin, and then targeting PDL1 and PDL2 overexpression with nivolumab and pembrolizumab. That's really changed the field.
I completely agree. 9p24.1 biology explains efficacy and guides patient selection. Thank you for your inspiration.
Okay, so let's move to the next question. Thank you, Professor. So next question is, PD-1 inhibitors have dramatically improved outcomes for HL patients. Even so, higher cure rates, lower relapse risks, and a better long-term management remain major unmet clinical needs. From a biological standpoint, which patients' grounds benefit the most from early immunotherapy and intervention? And do you believe PD-1 inhibitors will be moved to early treatment lines and further reshape the current HL treatment paradigm? Thank you.
Yeah, so I think two important questions that you ask. The first is, which patient group has really had the biggest impact? I think actually many patient groups have really been benefited substantially. Probably the two that come to mind are, one is relapsed and refractory patients. If you failed a transplant in the old days, we really didn't have a lot of good options for you. PD-1 blockade has really changed that, and I think many patients would, in the past, have now benefited from being treated with a PD-1 antibody in that circumstance. I think the other group that benefited substantially is older patients. Old patients didn't tolerate chemotherapy very well, so these newer agents, particularly the use of nivolumab and pembrolizumab, allowed us to use that in old patients and allow them to tolerate treatment a lot better. So I think those are two groups where there's really been a lot of benefit. The second question you ask is also a good one, is how has that moved into frontline treatment? And I think you're seeing across the board that it is now an established frontline therapy. The use of nivolumab with AVD in the US is kind of one of the standard treatments. The space that's beginning to move into frontline is in early stage, low burden patients, where now also there are studies testing the benefit of PD-1 blockade.
Thank you. Thank you for sharing.
That's very important, valuable information for our audience. Next question. Your research on HR immune evasion and microenvironment regulation is very inspiring for our work. Our team is currently focused on aggressive T-cell malignancies such as TLBL and peripheral T-cell lymphoma. We are wondering how can these findings from HR tumor microenvironment and immune evasion research be translated to T-cell lymphoma treatment. Which mechanism and biomarkers have the greatest potential to translate disease application?
That's a good question, and it's actually a complicated question because I think the translatability has been good in some respects and quite challenging in others. What I mean by that is CD30, which I mentioned is a very valuable target in Hodgkin lymphoma, is also a valuable target in many T-cell lymphomas. And in fact, there have been, as you well know, trials of the use of brentuximab vedotin plus chemotherapy in T-cell lymphomas with very good results. So if there's some degree of CD30 expression, many times brentuximab vedotin would be added. That's a targeted therapy. That's not really the immunotherapy.
Yes.
When we look at how effective PD-1 blockade is in T-cell lymphomas, about a third of patients benefit from the treatment. However, there have been a number of patients where there has actually been hyperprogression or immune activation, which seem to happen. So I think immune checkpoint therapy has been a little bit of a mixed bag, if you like, in the world of T-cell lymphomas. The one final thing is, what are we learning about the immune environment? And I think that's the challenge, is we want to get the immune cells, the good ones, to fight the cancer really well in T-cell lymphoma, but at the same time not do anything to activate bad cancer T cells. And that's where it's a little bit difficult because our treatments are not super specific where they only work on the good immune cells. They also seem to activate the bad ones. So lots more research is still needed.
Yeah, thank you for sharing. Exactly. Double-edged sword effect in T-cell lymphomas perfectly illustrates why specificity matters. We need smarter strategies to separate good from bad T-cells.
Thank you for your perspectives. Thank you. So last question for you is, with the rapid development of modern immunotherapy, the treatment landscape for Hodgkin lymphoma has become more and more diverse. So could you please share your vision for the future roles of autologous stem cell transplantation, cellular therapy, and the novel immunotherapies in HL? Also, will emerging biological findings enable more precise patient stratification to identify patients who need intensified therapy and avoid unnecessary overtreatment? Thank you.
Yeah, so some very good questions there. So firstly, I think the question about intensive therapy, like transplantation. Certainly, I think in relapsed patients, autologous stem cell transplant is still very much a standard. But there are a number of trials looking at low-risk patients who only had modest treatment in the very first line, seeing whether you can do treatment that doesn't include a transplant and if that is still going to be successful. So I think that is data that we're watching with great interest. However, I still think there are going to be quite a lot of patients where a more intensive treatment like a transplant is going to be necessary. So could you replace that with a better, different therapy? And I think immunotherapies and CAR T-cell treatments are opportunities there. But as you know, so far that's been a little more difficult than we thought. So while there are good bispecific antibodies and CAR T-cell treatments and even bispecific engager treatments that have been tried, the responses are very high, but the durability is not very long. And in young patients, we really want to see curative therapies. So that's where I think the future challenge is how to make bispecific antibodies and CAR T-cell treatments in Hodgkin lymphoma have more durable results. And ways in which I think we might be able to do that, there have been some ctDNA results that actually allow us potentially to understand different groups, and we might be able to stratify, to the question, stratify patients a little bit better using some of these ctDNA approaches and hopefully get better results.
Thank you. That's all the questions for you today. And on behalf of Hematology Frontier, thank you again, Professor. It's a big pleasure for us to have you here.
Thank you very much for having me. Thank you.